good to go.
Yeah. All right. Well, we've all met before, so I'm not going to reintroduce myself, but thanks for letting me talk to you guys. And what I wanted to talk to you today is about medical monitoring, specifically how medical monitoring has evolved over the previous decades and centuries, and the role that AI will play in medical monitoring in the future. So, unsurprisingly, in medicine, information drives clinical decision making. We need information to figure out what's wrong with the patient and what is the best treatment for them, as well as to follow them up to see how they're doing after the treatment. The information that's available today in modern medical centers is vastly larger than what was available even several years ago, but especially several decades ago. And the history and physical exam have been part of medicine since its inception, and they provide the most basic forms of information that guide our diagnosis and treatment. But today we have other things like lab results, imaging, real-time monitoring, and these all contribute to the overall picture of the patient's condition, and they help guide us in our clinical decision-making for those patients. Artificial intelligence has become increasingly incorporated into everyday life, as we know, and this includes in clinical settings as well. As AI continues to improve, its role in medicine will continually expand, and we'll look at one part of that today, which is medical monitoring. And so we'll look at what monitoring looks like today, what it looked like in the past, and how AI incorporation into medical monitoring may help to improve patient care in the future, and how it's going to change how we care for our patients. So we'll go back, way back. So in ancient times, we didn't have lab tests, we didn't have monitoring. We really just had observational details. We look at the patient, we can tell what their condition is, maybe ask them about their complaint, use physical exam findings. And actually in doing research for this, I was surprised to know that the physical exam was largely neglected until a few hundred years ago, mostly because of trying to respect the patient's body. So they didn't, especially male physicians to female patients, they would forego invasive exams, what we would consider pretty standard today. And so this was the norm until the 17th to 19th centuries, when we had devices such as the thermometer, the blood pressure cuff, stethoscope, when these were developed. And these allowed for more objective assessments of our patients, and we could then document these measures and keep track of them over time. Going back to Hippocrates, he was among the first to believe that diseases were natural and they weren't caused by the gods. So he described things like clubbing of fingers as manifestations of disease, categorized diseases, performed early thoracic surgeries, and started to keep medical records on clay tablets. And so all of these clinical decisions were made with minimal information compared to what we do today. In 1550 BC, the Egyptians were noted to correlate peripheral pulse to heart rate, and then 2,000 years later, at the time of Galileo, discovered the principle of the pendulum and used it to time the heart rate. And so these are kind of the increments that we made in medical monitoring of patients. The 20th century was a period of great advancement for medical technology and monitoring. In 1903, the string galvanometer was invented, and this was the precursor to our current day electrocardiogram. So this measures the electrical signals of the heart and tells us what the heart is doing. In 1925, Dr. Mackenzie emphasized the importance of graphical recording of vitals. And in 1949, Norman Holter invented the ultramonitor. So this is continuous monitoring of our heart rhythms that today we use for 24, 48 hours or longer. In 1952, the cardiotachoscope was developed. So this is a machine which provides real-time ECG tracing and heart rate monitoring during surgery. Moving on to the 1970s and 1980s, we started to incorporate all of these monitoring techniques into monitors that report all of the rhythm tracings, heart rate, blood pressure, respiratory rate, oxygen levels. In the 1990s, the development of the modern-day internet expanded our ability to remotely monitor patients and view the results. Today, the developments of these previous decades are still in use. So in-hospital monitoring today still includes continuous monitoring of heart rate, resp rate, blood pressure, oxygen levels, ECGs. You can now get tracings from arterial lines. You can put in pulmonary artery catheters and monitor hemodynamics. And this data now is collected automatically and is uploaded to the patient charts. And a good example is anesthetic records. So the anesthesiologist doesn't have to sit there typing away anymore. The data is automatically collected from the machine, gets uploaded into the patient chart. You can view it at a later time. And the real-time monitoring is possible from anywhere in the hospital. So if I'm sitting in one part of the hospital, I can look and see what my patient's heart rate is doing, what their blood pressure is like, what their X-ray that just went up is like. So I don't have to be in front of the patient anymore. And testing now comes with some automatic reporting. So a good example of this is in our ECGs. So if you get an ECG, as soon as it comes out of the machine, it comes with a little report. So this is up here. So this one is diagnosis, sinus arrhythmia. And that's done by the machine. So this is very basic diagnostic information, and basically what we do is we set reference ranges, and then the ECG can pick out if something is outside of the reference range. We have the same thing with lab tests. We don't need somebody to mark every abnormal lab test. We have automatic reference ranges that tell us what's inside or outside of the reference range. Same thing with heart rate, with blood pressure, those sorts of things. But today, communication is still from the machine to the human, and there's not a lot of machine-to-machine communication that happens. We're getting more sophisticated in our monitors, so we have things like smartwatches that can monitor all these things: heart rate, blood pressure, oxygen levels, fitness, some ECG tracings. We have continuous glucose monitors. We have EMGs that are wearable, can look at stress, sleep quality, hydration, medication adherence, behavioral monitoring. So our monitoring is getting more sophisticated, but again, the analysis of it is still largely done by humans, or there's some sort of alarm for when things go outside of the reference range. So I wanted to look at how we can integrate AI into our medical monitoring and how this is going to look in the future. So the first step is going to be looking at 2030. Now, 2030 is in the near future, and this is to say that we have the technology today, but we haven't integrated it into medical monitoring quite yet. But with these advances in AI, it allows us to have more rapid processing of data and quick teaching of these AI models, so we can teach them to look for abnormalities in some of our tests. One good example is in chest x-rays. So we can integrate AI, or we can teach AI to read chest x-rays and to pick out on abnormalities or to report what's normal. You still require input from the chest x-ray itself. That has to be sent to the AI. It puts out a report, and then the radiologist still has to review it and approve it. And one example of this is Q x-rays. This is the picture here. It's from a website. But they show that you've uploaded a chest x-ray. It's picked out where some opacities are. It's given you a result. And the radiologist can read this from their phone and can confirm whether this is correct or incorrect and can upload their own information. We talked about real-time monitoring, so our patients are on monitors and they have all of their data recorded, and then when something goes outside the reference range, an alarm goes off, but it's not really smart. What we can likely do is integrate AI into this continuous monitoring to start to pick up on what is normal or abnormal for the patient rather than what's normal or abnormal in general. So a heart rate of 101 is an abnormal in some patients, but it'll set off an alarm. Sometimes a heart rate of 95 is abnormal for the patient, but it's not going to set off the alarm, and that's where the clinicians come in to look at that data and make an interpretation. So potentially teaching the AI what's normal, what's abnormal, and then it can learn from the patient's own data to pick up on early signs of deterioration and can start to flag those for review. Ideally, we would start to integrate history, physicals, lab values into the information that's fed to the AI so it can make more appropriate decisions about what's normal or what's abnormal for the patient. And like we heard about last week, we can have things like Dr. Ware, where you can continuously monitor patients either in hospital or at home to pick up on early signs of, again, deterioration or worsening condition that can allow us to intervene earlier for the patients. Moving forward a little bit more to 2050, so now we have some more advanced technology, our AI is better, it's more integrated into the system. What is healthcare going to look like? And I think kind of thinking about how the patient moves to the hospital is helpful for this. So you still have a patient, they present to the emergency room, again we're assuming they're stable, they're not coming in with, on an ambulance. They'll walk in, instead of talking to a charge nurse, they're going to have to go to a kiosk. So they walk up to the kiosk, they put in their information, they put in their chief complaint. The AI will figure out what kind of pertinent questions it needs to ask. We'll triage the patient, we'll give them a monitor that they can put on and wear in the emergency room. It'll decide on what labs need to be done, at least as a baseline, send the patients off to do the labs. While they're in the emergency department, this continuous monitor will keep an eye on their vitals, we'll keep an eye on their electrical heart rhythm tracings, and we'll figure out if there's some sort of issue, and it can change the triage for the patient. So maybe they're triaged as less urgent, but once they put this monitor on, it's found that their blood pressure is low or their heart rhythm is abnormal, they'll get moved up the queue and they'll be seen faster. Once they're done from the waiting room, their labs are done, any imaging done, you have some baseline vitals, they'll get taken to a room, they'll still get seen by a physician at that point likely, they'll have to examine the patient, they'll add some more information into the chart, if there's any labs that are missing, they'll be ordered, they'll review anything that's there. The AI will likely, with all that information, give you a differential diagnosis, percent likelihood of each one, some basic treatment plans, but ultimately the final decision still will have to be signed off by a physician. And the communication at this point is still largely machine to human, so you still have to send that information from a machine to a human. This is not because the AIs are worse than us at diagnosing or treating patients, but it's because of the way our healthcare system is structured. So we're very averse to adverse events, and humans are more forgiving of humans making mistakes than AI making mistakes. We can see that with self-driving cars. Every time there's one self-driving car accident, it's all over the news, and we got to shut these down and regulate them. But we don't account for that every time that a human has a car accident. So this will likely be a point where the technology is good enough to take on these roles, but where our trust hasn't quite gotten there yet. And moving on to 2100 and later. So now we're way down into the future. Medicine's been largely taken over by AI and machines. And so again, thinking about how the patient moves through the emergency department, I think the first part is still similar. You still come in, you still walk up to a kiosk, you put your information in, put in your complaints, have your labs drawn, have some images taken, your triage. You're then moved into a room where likely now the physician doesn't have to examine you. So you can either use some sort of advanced imaging to scan the patient from the outside to get things like their respiratory rate, their general appearance. You could potentially have even, robots that can now do the physical exam themselves. We have sensors that are very sensitive to touch, and so there's no reason why robots can't take on that part of the patient's examination. Again, at that point, we can figure out a differential that gives percent likelihood based on all these findings, come up with a treatment plan, send the patient home. They might never have to be seen by a human. I still envision at this time that there's going to be people in the emergency rooms. But instead of having, we have 5 pods in our emergency department, having 5 or 6, ER physicians and dozens of nurses, most likely we're going to have 1 physician, maybe a handful of nurses, and this will be for things like putting in lines, if there's a code, running a code, if there's some sort of issue with the system, you have somebody to take over, but it's going to greatly reduce the workload on the humans that are working there. Communication at this point is going to be largely machine to machine, but again, you still have humans there just in case. The staff scheduling, I think, is what's going to change the most. So you still have to have people working there, but instead of having a 4 or 5 day work week where you're working 12 hours a day, this is going to be cut way down. So maybe the ER is still staffed with the same number of people, but now they're working maybe 1 day a week or 2 days a week, and for shorter shifts. This is going to improve the quality of life for the people that are working in the emergency department. It's also going to improve the wait times for the patients because the throughput will be a lot faster, so you have less people waiting. I see that at discharge, you're going to have more monitoring of patients. So instead of sending patients home and having them come back in a couple of weeks to get follow-up, they'll likely be sent home with a wearable device. They'll have their vitals monitored. Again, if something starts to deteriorate, if they start getting worse, either they'll be instructed to come back in or EMS will automatically be called to go pick the patient up and bring them back to the hospital. Appointments, follow-up appointments will all be automatic as well. So if the patient comes in with atrial fibrillation, they get cardioverted in the hospital, they're stable to get sent home with monitor. Referral is sent to your outpatient cardiologist or cardiology clinic run by AI, and then the patient can get followed up later. And so, just kind of to summarize here, artificial intelligence has advanced exponentially, and it will continue to improve over time. And while it's great at learning one task, it still struggles with combining multiple complex tasks or very detailed data about things, and we see that in medicine when we ask it those detailed questions. The current and the near future applications of AI likely include analyzing data points, finding warnings, early signs of deterioration, but the complex, complete patient management is far off, likely several decades away. Part of that is going to be needing this, enough technology advancement to get to that point. The other part is going to be having us as humans and patients trusting AI to make the decisions alone without oversight from a physician. And so, even with these advancements, healthcare professional-free ER is likely in the very distant future, in my opinion. And so I think the transition to AI-based hospitals and AI-based emergency rooms is going to be gradual. It's going to be a slow shift of responsibility to the machines that's going to start with just reducing the workload on the humans that are working there without compromising the patient care because you still have oversight. Like I talked about before, any setbacks are going to include a loss of trust if there are mistakes. And so this is what I think is going to really hinder rapid takeover of AI in our hospitals, because a single fatal mistake by AI or because of AI is going to be viewed very harshly and will likely result in complete review of the system, and now we have to figure out, okay, is this appropriate? Have we gone too far? Do we need to slow down? It'll slow the transition, but it'll never stop it. It's going to keep moving that direction gradually until we're at the point where AI takes over and machines take over our healthcare. Advancements in material science are going to be very important. So when we have biocompatible sensors that are less burdensome, the picture I showed you with the patient wearing that thing over their chest, people don't like to wear that for 24 hours at a time, but if you have biocompatible sensors or something like a watch that can take all of this information, and this is going to allow for home monitoring, likely will make it a bit more cost effective to send patients home with this, and more likely to improve compliance. And with the more information that we have, the better decisions we can make for our patients. That's my presentation. I'm happy to answer any questions.
So could we reach a point, do you think, where medicine is mainly well care rather than sick care, and that the main challenge is human augmentation, what's possible, what can be allowed, and that sort of thing? How would you feel if that was the case, if almost nobody got sick anymore, but they just wanted to get better, you know, and like in every possible way?
Yeah. So I mean, that's I think the dream for all physicians. You know, an ounce of prevention is worth a pound of treatment, and so you know, I'm a cardiac surgery resident, so when I'm going to be doing heart surgery on patients, my dream is to never have to do a heart surgery on a patient.
Yeah.
You know, if you can prevent heart disease, it's way better than treating heart disease. That's unfortunately not the world we live in. You know, we have many ways now that we can prevent disease. Exercising more, eating healthier. If you have high cholesterol, take a statin. If you have diabetes, take your antihypoglycemics or your insulin. But we still see patients come in with out of control hypertension, out of control diabetes, who come in with MIs, who come in with aortic dissections. So it's not to say that we don't have the information or the medicine to prevent disease, but compliance is a big issue. Genetics is something that we're never, I can't say never. In the near future, we're not going to be able to change. Maybe down the road we can start genetically editing humans, but that's again way down the road. So there are certain things that will still result in sick people. But today, right now, we could cut down the number of people coming in for lots of the procedures that we have: knee replacements, CABG, aortic valve, replacement or dissection repair, or whatever it may be, if they just followed all of the guidelines and every recommendation of their doctors to the T. But that's not how humans work. So until there's a behavioral change or a cultural change in how humans interact with healthcare, there's always going to be sick care for patients. That's not something I think we'll ever get rid of. But in a world where people are more open to wearing these monitors all day and taking care of their health, definitely we'll see a shift away from treatment and more towards prevention. Because when you're at home and your blood pressure all day is 160 on 105, and you get that monitor going off, you're more likely to go see your physician than if you never see a doctor for 10 years and don't know that it's going on. So that increase of information will certainly allow us to pick those things up earlier, but it'll never be 100%. At least not in my lifetime.
So other questions?
Not to be doomsday, but what if there's a scenario where, let's say the AIs begin to malfunction? I'm talking more in your 2100 scenario where everything is automated. Who's responsible for fixing them? Or would it be potentially the one ER physician in the hospital and their handful of nurses? Do they know how to fix it? What do you see happening in that?
Yeah. I think if we're at the point where AI is running our healthcare system, we also have good enough IT support that's also run by AI to fix problems as they come up. So, healthcare won't evolve in isolation, and I think probably will be the slowest to evolve of other areas, for the reasons that I mentioned. So I assume that we'll have good enough technology to allow us to fix problems as they arise. Now, this is why I said you still need people around, right? So I don't know, you can have a robot do a physical exam, but how good is it going to be at finding a vein in an arm and getting a catheter in? That's a very simple procedure for humans, but takes a lot of fine movement that is going to be challenging to teach to a robot, especially with trying to visualize veins. So I still envision people being involved, and if there's a scenario where the machine shuts down, again, you still have people employed in the emergency room that can take over for a short period of time. If you have 50 ER docs that all work one day a week, but one day all the machines are down for some reason, you can't fix it, you have people that you can call on to come in. So you'll have a much less burdened system that can take on more of these responsibilities if the AI malfunctions. But if we're at that point, I would think it would be very unlikely that you'd have a complete shutdown without an AI quickly jumping in to fix the problem.
So our whole medical care system is structured around things being scarce. Resources, the workforce, everything. Do you think we'll quickly reach a point where we have, a abundance medicine where there's a surplus of everything, or do you not see that in your lifetime?
I don't see that in my lifetime because number one, the AI is not going to be for free. So I'm sure whatever company devises it that proposes to the hospital that you can save $10 million in physician salaries a year is going to request $10 million in compensation for running the system, providing it, and keeping it moving, keeping it functioning. But again, you also have to think about the people involved. That's going to be the big challenge. So if you say to the nurses in the hospital, we are going to cut 90% of your hours to integrate this new AI system, if you're not still paying them something comparable, the union will get in the way, or they'll all walk out and you can't run a hospital anymore. And so there'll be a barrier unless you can continue providing livable wages for nurses, physicians, technicians in the hospital to keep the hospital running in those cases. So the cost of running the hospital is not going to go down. The cost of the medications won't necessarily get any cheaper. The patients that we're seeing in hospital today are actually older and sicker than they were 20 or 30 years ago. So the amount of resources that they're using today is much more than they were. And that, I think, will continue down the road as people live longer, they have more comorbid conditions. The patients who live till they're 90 years old are likely to have more than one problem than they did before. Again, assuming we can't prevent those diseases. And things like organ transplantation, there's still shortages of organs that we haven't addressed yet. Patients who come in with heart failure need an LVAD. That LVAD still costs $100,000 a year to operate. So the AI maybe will provide better care and some treatment, but if it can't get rid of the disease, the burden is still going to be quite high. And so, again, not within my lifetime. One day, I hope that we'll be in a system of abundance. But as far as I can see it, I think we're still going to have these problems with limited resources.
Yeah.
Have you come across any developments or future predictions on ECG monitoring? Because ECG is basically lie on a piece of paper or a screen, and if you somehow integrate patient information like their comorbidities or their appearance status, their vitals, their appearance or whatever, do you think ECG could move towards completely AI-based? When do you foresee AI being the predominant ECG interpretation methods instead of human?
Yeah, I think with the technology we have today, and like you mentioned, ECG is actually quite basic, right? It's lines on a piece of paper, and oftentimes if it's, for us, we just have a gestalt, so you can look at it and say that's a STEMI just by looking at the paper, but you don't have to actually look. But when you're unsure, what you do is you go down and you take a little ruler and you start measuring boxes. So is this one box or two box? Is it a big box or a small box? And so it's very much a numbers thing where you're looking at the numbers. So I think with the technology we have today, you could design an AI to read ECGs just as well as any, at least any average physician, and probably, a cardiologist, or at least in the near future. Again, it's the point of when is that going to be let go? So when can you go to a group of cardiologists that all read ECGs and say, here's a technology that reads the ECG better than you do, and so we're not going to pay you anymore to do it. They're not going to be likely to give that up. So I think there might be a point where the workloads are high enough that they would say, okay, if we can offload something to reduce our workload, we'll do it. But I think that's probably still 10 or 20 years away before people are willing to completely let go of that. Again, the trust is a big thing. So sure, you can automate it, but now you have every day thousands of ECGs that aren't being seen by a human. How many of those have an error that's not going to be picked up? And so that, I think, will slow things down. But again, I think today we have the technology to do it, but it's just when is it going to be integrated? Similar to my 2030 slide, we have the technology today. It's going to take 5 years before we can actually get into healthcare.
So when you had mentioned there was a slide that you were talking about how an X-ray can be submitted, and then AI can kind of analyze it, yeah, that one, and then the physician can simply just confirm whether what the AI had already picked up is correct or not. So when I was thinking about that, I was kind of looking at it in terms of, do you think that could maybe, if you not used appropriately, it could make physicians less or more dependent to the point where if they even disagree maybe with what's going on, because the AI has said something, they're yeah, sure, that seems right enough, and they confirm it. Don't you think that could create problems? Or
100%, yeah. So this is one of the big problems with having these AIs around, is that you then start to trust them, and when you trust them, you offload them. But it's the same as what happens now clinically. So again, in cardiac surgery, so I think that I should be able to read an angiogram and read a CT scan. But if I read a CT scan, I look at the heart, I look at the aorta, and I look at the lungs. But when I get to the abdomen, okay, sure, I could pick out like some catastrophic thing that's happening in the abdomen. But usually I look at the CT report and I see what the radiologist said because they're the expert and I trust them. Are there times where, you know, I've picked up things on a CT report that are wrong? Because that happens, people make mistakes, that's not, you know, not a big issue, but it is there. So, you know, I am reliant now, if you replace the radiologist with an AI, it's the same thing. So I trust them because they know what they're reading. So you can definitely get into that situation where as a radiologist you read 5,000 of these scans and the AI is right every time, you might be less likely to double check these things. But again, that if it's going to reduce your workload, you're still liable, in the near future at least, to be making sure that all of these are read correctly. So it's going to be a balance. You're for sure going to have people who become reliant on these things and, you know, miss things once in a while. But it'll be a gradual transition. So eventually that'll get picked up. There'll be some big review about it. Okay, why was this missed? And then, okay, we have to pay more attention to our chest x-rays. That goes away for a little bit and it'll kind of wax and wane. But in the long run, it'll continue to increase with our reliability on AI.
Yeah?
Quick question that I have. First of all, that was a great presentation. You mentioned how AI can maybe reduce the burden on human workers. Do you think it's possible that with advances in AI, it will open up opportunity for new sorts of treatments that will instead increase the workload of physicians in a way that maybe technology today is much greater than what we had in like the 18th century, but physicians don't necessarily have to take a break or less?
Absolutely, yeah. So I think that is going to be one of the biggest benefits if used properly of AI is identifying new treatments. So, you know, the way that we used to identify new treatments 30 years ago is we would come up with a drug that we kind of have an idea about how it works, and then we give it to a rat, and then with diabetes, and then we see if the rat gets better, and then if it does, then we give it to a pig, and then, you know, maybe we give it to a chimpanzee, and then we give it to a human. And the process of drug development took years or decades before it got into clinical practice. What we see now is there are AIs that can predict folding of proteins. And so if you can feed the, you know, very specialized AI information about this disease happens because of this specific protein, how can you design another protein or another enzyme to latch onto this in a correct way that you know, the right way that you inhibit it, and then you can treat this disease. And so there's a potential to have very rapid development of drugs that you can then kind of accelerate the rate of from, you know, design to implementation. And so I you know, as long as it's medications, I don't see it being much more burden on the physician, but definitely I think that is going to outpace the actual takeover of AI in care itself, is that the development of these treatments. You can also screen thousands of molecules, so you can give it, you know, you can create a bank and say these are 10,000 similar molecules, I want to screen all of them, and it can screen them out for you and tell you which one is going to have the most binding efficacy to a specific protein. And again, help you screen through all of those versus taking 10,000 or 20,000 mice, giving them all the, you know, 2 of them each of these drugs and seeing how they react. So.
Okay, great. Thank you very, very much.
Yeah, thanks everyone.
You can